Hello, everyone. I'm Dr. Park Byung-gyu, and it's a great honor to speak here in beautiful JEJU Island. I sincerely thank Dentium for the kind invitation. I'm a periodontist, and I would like to enjoy new surgical techniques and also new materials. And I believe that is the reason why I'm standing here today. But my topic is about titanium mesh, something many clinicians don't use very often these days. It's kind of old-fashioned, but I brought it. Why? Because we sometimes need it. In my daily clinic, I like to use, today we learned about many presentations. Through those presentations, we learned that the simple implant placement is very useful. And I also like to use this narrow implant, like brightest level, because narrow is very strong. So we can place it in very narrow spaces. And also, sometimes the inferior adult nerve is very close. It's very hard to place even short implant. I can place the implant angled, so I can avoid nerve damage. And also, when you place multiple implants, but it's not easy to place it parallelly. So within 40 degrees, with the bright tissue level implant, we can make the procedure, prosthesis, in one piece. That is very useful for multiple cases. And next, even in a very narrow ridge, like an anterior lower area, we have to place very thin, narrow implants. Usually we use it, not two-piece implant, we just use the one-body implant. But with the bright tissue level implant, we can make the prosthesis with a two-piece. That is very good for adjust the path of the prosthesis. So I like to use these systems. So, but what I want to talk to you is not about these simple approaches. I like it, but not today. I like to talk about a small number of cases that fall outside the standard deviation. Cases that are uncommon, but often the most challenging for us. If you look at the socket classification by Gulungman in 2017, when you see the class 5, after tooth extraction, this socket became very challenging for us. Even though the frequency is quite low, 1 to 2%, but when you encounter these cases, they are very difficult to manage. So today I would like to talk about these things. After tooth extraction, we encountered this very narrow result. So in this case, when we only use a resorbable membrane with a particulated bone, the graft is not well protected. Under external pressure, it can easily collapse and become scattered, and even it may resolved. I'm going to show you a case. This patient came to my dental clinic for the placement of tooth number 34, but as you see here, the ridge is quite narrow. So I tried the Vista technique and resorbable membrane to build the volume. So I packed a lot of grafting materials. But a few months later, when I opened the lab again to place the implant, most of the grafting material was disappeared. So I had to perform GBR again. And after the CD view, placing the implant, as you see, it's very unstable. I worried a lot about this case. But fortunately, I could finish the case, and I followed. After 5 years later, the implant still survived, but as you see, it's very unstable state. So, because of these limitations, many professors provided several techniques: ridge split technique, sausage technique, split bone block technique. Every technique have its own advantages and disadvantages. If you look at a recent publication from ITI this year, they emphasized selecting the membrane based on defect morphology. For content defect, type 1, like internal defect, they just suggest a simple resorbable membrane is sufficient. But the defect becomes more severe, especially when there is vertical collapse. They recommend using non-resorbable membranes or sometimes titanium mesh. So the key is this: as the defect becomes more compromised, you need a more rigid structure, something that can physically maintain the space. And that's the critical factor, I think. And if you look at the systematic review about vertical ridge augmentation by Dr. Obran in 2019, they compared the various techniques and materials. With the resorbable membrane and particulated bone, we can get about 4 millimeters of vertical gain. But with the titanium mesh, we can get more than 5 millimeters. And another systematic review. This review prepared a lot of graft materials, and they concluded that with particulated graft alone, we can get 3.7 millimeters of bone gain by horizontally and vertically. But when titanium is combined, the number goes up to around 6 millimeters. So across multiple studies, we constantly see better outcomes when titanium mesh is used. Which means in unfavorable defects, especially uncontained defects, titanium mesh can be a reliable option. So in my practice, when I made an uncontained defect, my first choice is titanium mesh. Titanium mesh has many advantages. First, it provides very reliable space maintenance, even in a large defect like this patient. The patient came to my clinic for the placement of implant, Furachi implant here. But the patient used the denture for a long time, so as a result, class 3 low-jaw relationship developed. At first glance, I thought that it's impossible to place the implant. But with the titanium mesh, I was able to achieve a significant amount of bone augmentation. As you can see on the CT view, the jaw relationship also improved. And not only that, we could also see the patient's facial profile was improved too. So overall, titanium mesh allows us to achieve both functional and aesthetic improvement in challenging cases. Another advantage is like this one. We can make the defects. We can change the coverage. We can make the coverage here. Even in covered area of arch, like canine area, I can trim and adapt it to the desired shape. So in this case, despite severe alveolar resorption, I was able to restore the arch bone well and achieved a good aesthetic result. And another advantage is very useful for vertical augmentation. Yeah, the ridge is completely resorpted, so in both buccal and lingual direction, almost down to the apex. If you look at the vertical discrepancy here, it's almost more than 10 millimeters. So it's very severe collapse. But even a case like this one, we place grafted material and place titanium mesh and fix it firmly. And then we can get the good result. As time goes by, we can get a lot of, we can see that a lot of vertical augmentation was gained here after 4 years later. So to summarize, titanium mesh maintains space very well. We can shape it as we want, and it's effective at both vertical and horizontal augmentation. Because of these advantages, it's a very powerful and useful technique. But nowadays, you don't use this titanium mesh very often, I think. Because? Why? Because it's not easy to handle it. Somebody say it belongs in a museum. Yeah, nowadays, you don't use it. The reason is there are several practical challenges using this titanium mesh. I'm going to show you one by one. First, adaptation. Shaping and bending the mesh inside the mouth is not that easy. Although I used suture material package paper as a template, but still it's not easy to make the shape. And next, even if you manage to shape it, and once you place the grafted material, and then try to cover it with a mesh, try to cover mesh, you will never completely sure whether the graft is properly positioned underneath, because sometimes there is a void, sometimes it's underfilled, sometimes it's overfilled. So the mesh doesn't sit properly. So many clinicians feel it's too difficult to manage it. If one of you try this technique, it's too difficult. And also, one more thing. We have a very high exposure rate. It varies across studies, but the risk of exposure is still significant. So this is a major source of stress for clinicians. And also we have to remove it. We need another surgery. Taking the mesh out is not that easy because the soft tissue integrates through the pores. There is a lot of resistance during removal. And if you're not careful, you can damage the tissue you made, or you may remove the hard tissue you made. So sometimes, although I made a lot of hard tissue here, but also I need another additional graft. In this case, I use collagen graft S2D to make the soft tissue volume thicker. So these processes are so demanding. That is the reason why you don't use this titanium mesh nowadays. So the question is, can you make the titanium mesh easier to apply, to use? For me, the answer comes from the Dentium GBR plate. So today I will tell you how we can simplify the procedure using this system. This is Dentium GBR plate. It has both large pores and small pores. The large pore is about 3.5 diameter, so they are big enough to allow bone graft material to pass through. And small pore is 1.5 millimeter pore. This is for the fixation. The pin and screw can go through the hole. And the thickness is about 0.2 millimeter. So it's flexible enough to be bent and adapted, but still rigid enough to support the external pressure and maintain space. So I use this mesh like this way. First, I fix the mesh using a screw into the small hole first, and then I place graft material through the large pores. This is a very good advantage. This is the major advantage of using this system. But before, when I used the small titanium mesh, which is a very small pores, I had to place the graft first and then cover it with the titanium mesh. Sometimes it was underfilled, sometimes overfilled, as I told you. Sometimes I had to push the graft material from the side. It was quite difficult. But with this approach, it's very easy. We fix the membrane mesh first and then graft it. It's quite easy. And also, the mesh has multiple poles, and after implant placement, I can connect an underabutment or a fixation screw to the implant. Then I can secure the mesh and membrane all together. So this is very easy to use. But there is one important limitation. With this kind of titanium mesh, especially with the large pores, we lose one key property of a membrane: cell occlusiveness. In other words, a membrane should block soft tissue ingress and allow bone to regenerate underneath. But because the pores are large, so the mesh alone cannot prevent the soft tissue invasion. So it doesn't function as a barrier membrane by itself. That's why you should use it with collagen membrane, together with the collagen membrane. So after placing the graft materials, we always have to place these collagen membranes. That way, you can maintain the space well and achieve good cell exclusion with the membrane. And another step. As I told you, it's not easy to bend the titanium mesh inside the mouth. So recently, we are seeing more customized meshes worldwide. Using CT data, you can design a mesh that fits defects exactly, and then just place and fix it during surgery. It's much simpler. But in Korea, the market is relatively small, so it's difficult to find a company which provides those customized titanium systems. So in my clinic, I take the CT view and I convert it into a STL file and I print it and make a model. And then from the model, I pre-bend the titanium mesh before the surgery. And then I can place it. In the past, converting the DICOM file into STL file was quite difficult. You needed specialized software. But now, with Brighter CT, there is an AI segmentation feature. It automatically converts the jawbone into an STL file. So you just export and print. It's much simpler and much more practical. Without this technique, it's very hard to place and adapt the mesh inside the mouth, especially in a patient with a very small mouth. So I generate an STL file here, print the model, and prevent the Dentium GBR plate in advance. Then during the surgery, I place implant first, then fix the mesh, and simply pack the bone grafting material through the pores. This way, the whole procedure becomes much easier and much predictable. The next question is, do we always need to full coverage with the mesh? Especially in very thin ridges, do we have to completely wrap the defect? Not necessarily. In cases we need only horizontal augmentation, the main issue is the graft collapsing or flowing out along the lateral wall. So instead of a full coverage, you can simply place the mesh on the buccal side or lingual side, like a fence shape. It's very easy to bend it because when you want to cover the whole side with the 3D bending, it's quite difficult. But fence shape is it's easy to make those shapes. So I prefer to use this technique too. And let me show you a case. This patient had a very thin alveolar ridge, especially in tooth number 11, 21, and 22. She had an accident, traffic accident at her younger age, so which interfered with the maxillary anterior growth. So overall, the ridge development was compromised. So when I opened the flap, I could see the flap was very thin, and also the ridge was extremely thin. So I performed cortical perforation, and then I proceeded the titanium mesh with the fence shape on the buccal side first. But not only the buccal side, but also the lingual side, I placed another titanium mesh. Approaching lingual side is quite difficult, but with the fence shape, the procedure becomes much easier. And then I placed bone graft material, xenograft materials. Let me skip for a moment. And then I placed, as I told you, the titanium mesh itself cannot prevent the soft tissue invasion, so I placed the collagen membrane and collagen graft too. Especially on the ridge area, I placed the collagen graft to thicken the soft tissue thickness. And post-operatively, as you can see here, the area that was extremely thin is now well filled with graft material. And once this goes ossification, it creates a much more favorable condition for implant placement. At 6 months later, I'll remove the mesh because it is positioned in a fence-like design. I do not need to open the full flap. A small lateral incision is enough. A small lateral incision is enough for mesh removal. That way, I can remove the mesh more conservatively. Even though we exposed the screw holes here, we did not disturbing the supracrestal tissue here. This year. So we can maintain the vertical height much better. If we open the flap altogether, the flap maybe goes to thinner than before. So with this technique, we can preserve papilla, and also we can prevent gingival dissection too. So I sometimes call this one bone keeper technique. It's like a gold net, so I named it bone keeper technique according to my name. After mesh removal, I can simply close, but to increase the soft tissue here, to increase the soft tissue here, I placed collagen graft X1D to thicken to improve the phenotype, and the result is quite beautiful and clear. And this is the post-operative CT view. And then I also placed the implant here. At first, it was almost impossible to place the implant, but with a bright tissue level implant and titanium mesh in advanced technique, I could achieve it. This is before the surgery. And the patient is still under orthodontic treatment, so the final prosthesis has not been delivered yet, so sorry about it. But the patient is quite satisfied now. And with this system, you don't always have to go with the full coverage. You can choose full coverage or partial coverage depending on cases. So if you even use it in a fancy shape, it's very flexible. Even in cases like this, well, we need both sinus graft, sinus lifting, and we need sinus augmentation here. Also, we need horizontal ridge augmentation. So these cases are very annoying and very hard to solve with the problem. But with the fence-like configuration, using it, I can achieve the desired outcome altogether. Just one surgery, I finished the problems. And the last one, I'm going to talk about the last concern, mesh exposure. But we encounter mesh exposure very often. But one thing we have to think about is exposure does not necessarily mean failure. In terms of bone formation, if non-exposed cases achieve around 80%, then exposed cases may show something like 60%. But there is some reduction, but it's not a dramatic loss, and which means even if exposure occurs, clinically acceptable outcomes are still achievable. But one thing we have to remember is the timing of exposure. If the exposure happens earlier, soft tissue can grow into the graft material through the mesh, which can compromise bone formation. In those cases, it's better to remove the titanium mesh. But if exposure occurs after about 4 weeks later, a pseudo-periosteum has already been formed, providing some protection. So in that case, that situation, complete removal is usually not necessary. Simple edge trimming is often enough. I'm going to show you. This is the last case of my presentation. This patient came to my clinic to restore her anterior maxillar area. I planned the number 12, 21, and 22 to place implant here. But in this case, the bone was severely reserved after tooth extraction and all the way to apex, so I needed the vertical augmentation and horizontal augmentation too. At 3 months after extraction, the ridge became very narrow, so I placed titanium mesh, pre-shaped on a 3D model, and fixed it with the screws. We have to screw it, we could fix it very firmly. And then I placed the bone-coated materials and covered it with the collagen membrane and closed it. 11 days later, I removed the stitches, and the healing was fine, everything looks good. And when I took the CT view after the surgery, we can see a large amount of bone was gained here on the buccal side. Not only the horizontal, but also vertically, I achieved more than 2 millimeters to here. So it looks quite good, but unfortunately, 1 month later, she came to my clinic saying that something is coming out from the gingiva, and when I checked it, mass exposure occurred probably due to denture pressure. Fortunately, there was no sign of inflammation, so I trimmed it and exposed the portion. 3 months later, it was healed well with soft tissue coverage, but the problem was the mesh exposure was extending to the adjacent area, so I decided to remove all the meshes. But titanium mesh has a relatively smooth surface. It doesn't tend to promote bacterial infection, so it's not a big problem. After removing the mesh, for the exposed flap area, I used the collagen graft to X1D for protection, and this is the result of the surgery. And overall, the ridge augmentation was well maintained. Around the 5 months, I placed the implant, and also there was a small collapse here, so I placed the Dentium collagen graft to X1D and CTG2 to make more volume. And this is right after the implant placement. As you see, I could get a lot of hard tissue on the buccal side, and also vertically I gained a lot. And this is the final restoration. Even though there was some mesh exposure, when you look at the overall before and after, we were able to achieve an aesthetic, stable result. So time is almost over. So until now, we have seen different ways to use titanium mesh in a smart and efficient way. By pre-shaping the Dentium GBR plate, while using it in a fence-like design, we can handle these challenging cases more easily. We may not see these challenging cases very often, but when you do, they can be a good treatment option. So some people say titanium mesh belongs in a museum, it's an old style, but I say with this technique, this approach, fence-like shape, we use it, it belongs in your hand. Thank you very much for your attention. Thank you. If you have any questions, don't hesitate to contact me. I'm going to show you my email here, and Instagram is here, so you can contact me. Thank you very much. 谢谢。